Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. If you're attending virtually, you may enter your question into the chat, and a link to the event survey will be shared with you at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Vikas Kilaru. Dr. Vikas Kilaru is a third-year internal medicine resident here at Northeast Georgia Medical Center. He is from Michigan and went to medical school at Lincoln Memorial University DeBuss College of Osteopathic Medicine. He is interested in outcomes research in the field of cardiology, as well as the intersection of technology and medicine and community care. He is also passionate he also has a passion for improving the burden of healthcare on patients and healthcare providers. Join me in welcoming Dr. Kilaru.
Thank you. Thanks, Ms. Reagan. Thanks for having me, everyone. I'm happy to be here. My name is Vikas Kilaru. I'm a PGY3 internal medicine resident here. And I'm here to talk today about wearable cardiac devices in the modern landscape of cardiology. So let's get into it. I have no financial disclosures. The objectives for today, things that I hope you understand or get some better feel for after my talk today. Understanding the technological advancements and types of wearable cardiac devices, analyzing the clinical applications of wearable cardiac devices in diagnosis and monitoring, and evaluating the impact of wearable devices on patient outcomes and healthcare delivery. So let's start by getting some background and understanding the technology available. The accelerometer, which people are probably most familiar with, it's a device that collects data from 3 different axes of movement and can do activity monitoring and heart sound monitoring. Ballistic cardiogram, which is BCG, which works by displacement of the human body caused by myocardial contraction and blood ejection. It has the ability to monitor heart rates, blood pressure, and even myocardial contractility. Seismocardiogram, SCG, which measures chest wall vibrations and has the ability to determine structural abnormalities and even decompensated heart failure. And the limitations of all these in a large area of study for these is limiting the discrepancy with motion artifact. Photoplethysmography, probably my last time saying that during this presentation, or PPG, is a technology that's really benefited from advancements in LED and has allowed for progression in PPG sensors. In the 2000s, smaller sensors and more efficient algorithms have enabled the integration of these devices into consumer health products. These work by using LED that shines light, usually in a green or infrared spectrum, onto the skin. Blood vessels in the skin absorb that light, and the amount absorbed fluctuates with the pulsatile flow of blood. A photodetector in the device then measures the amount of light reflected back, which creates a waveform that corresponds to the blood volume, which changes with each heartbeat. So what can PPG detect? It can determine arrhythmias by demonstrating sensitivity similar to that of ECG-based monitors by analyzing heart rate patterns. It's a surrogate for blood pressure estimation using, while not as reliable as traditional cuff-based measurements, it attempts to estimate blood pressure by analyzing changes in pulse wave velocity. And our old favorite, SpO2 or oxygen saturation monitoring, which can monitor for hypoxemia and assess respiratory health in conjunction with cardiac function. Electrode technology, or single lead EKG, which can determine heart rate, rhythm, and even in some forms detect ischemia. This works by, there's a bottom surface of the watch, for example, which is one vector, and the second vector is when you place your finger on the side of the watch. And that's how it determines these rhythms and heart rates. Some of the basic technology of electrodes, wet versus dry electrodes, as you can see in the left, on the bottom left of this slide. There are those are the two main classes. A wet electrode uses an electrolyte that interfaces with the skin, and in contrast to dry electrodes, which just use the skin's moisture and sweat, to interface with the skin, and those interferences can cause impedance issues and are less reliable when using dry electrodes. Some honorable mentions for unique technologies. The RED system, or remote dielectric sensing, is basically this device that you can see in the upper left. Maybe you can see one of our, this might look like one of your heart failure patients that you recognize. It measures a % of lung congestion, and it uses this using the dielectric property of tissue. And then it basically represents it as this chart here, with a 20 to 25% being normal, and then these higher scales being indicative of heart failure decompensation or fluid overload. There are some data to support this, actually. In a prospective study of 50 patients hospitalized for acute decompensated heart failure, the use of this daily REDS measurement optimized outpatient heart failure therapies during a 90-day follow-up period and actually reduced heart failure readmission rates. So this device really has a lot of utility in both the inpatient and outpatient setting. Bioimpedance, transthoracic impedance with electrode on skin surface, and this correlates with intrathoracic impedance and is worn as a vest. There's actually studies with both of these devices that has shown them to be very similar to chest CT in predicting symptoms of fluid overload. So where did we start with all of this? The first pulse oximeter was invented in the 1940s and worked by squeezing out blood that you can see in the bottom left. There was also a device that worked on the ear, and both of them were rather painful, similar to what an ABG might feel like. The first modern pulse oximeter was invented in 1977 by Takuyo Aoyagi, and by the late 80s had been moving through first the operating room and subsequently into the ICU, especially in the NICU, where it's especially useful for preventing retinopathy of prematurity, or ROP. While the initial pulse ox that you can see on the left was very large, this is one of the technologies that has really benefited from the shrinking size of computer chips, allowing us to measure the pulse of the heart and hypoxemia in a bite-sized package. So, an unexpected clinical consequence of the development of open heart surgery was the discovery of treatments for complete heart block. Initially, Paul Zoll, a name you might recognize, was a cardiologist in Boston who invented the first pacemaker unit. It was actually a tabletop external unit with a chest electrode, but it used 50 to 150 volts of electricity and could leave blisters and was very painful, especially for children. I think it would be painful for me too. Complete heart block was a phenomenon that occurred in 10 to 20% of patients after VSD repair, or ventricular septal defect repair, and mortality of that was almost 100%. There was really no treatment at the time. So what was done is that this pacemaker was invented, which was externally connected to an AC unit and plugged into the wall. But patients, and actually mortality went down to less than 10% after the invention of this, but patients were initially connected to this AC unit and could only move with the length of that extension cord. Eventually, there was actually a company that worked in that hospital. It was called Medtronic Inc., another name you might recognize, that invented this is, as we can see on the left, the first diagram of an external battery-powered pacemaker. And this really allowed for a lot of the progress that has led to, as far forward as we are today, a tiny device that is inserted to the chest, and this is actually a leadless pacemaker. A wearable cardioverter defibrillator. This is the Zoll Life Vest, the brand name for it. It's an external device with a built-in defibrillator. The WCD, as it's known, is worn directly on the body by patients who are at high risk for sudden cardiac death. for short-term risk mitigation, doesn't require surgery, and is especially useful for patients who can't have pacemakers implanted at the time, or might not need them when those high-risk procedures are kind of further out. This is a non-invasive medical device, as you might imagine. It's just a fabric garment that's worn at all times for that certain period, except when taking a shower or a bath. And it records heart rate and rhythm and delivers shocks as needed. And the data supporting it is here, and it's actually one of the first, if not the first, wearable cardiac devices that was reflected in the guidelines. In 2004, it was placed into the guidelines after cardiac surgery with a decreased ejection fraction for preventing mortality, or rather improving mortality. This is, while not technically a wearable device and not the focus of today's presentation, the CardioMEMS device has been approved for patients with HFpEF and patients with heart failure with reduced ejection fraction by the FDA in 2014. It's an implantable device that's placed in a branch of the pulmonary artery, and it provides real-time monitoring of PA pressures. This is supported actually by multiple trials. The first big one was the CHAMPION trial, which used about 456 patients with reduced ejection fraction, and found that events occurred at a rate of 0.49, which is mortality and also primarily rehospitalization of patients, compared to 0.69 in typical care groups. While it didn't directly measure mortality, it did measure rehospitalization, and as we know, this is sort of like a surrogate for increased mortality in heart failure patients, because repeat hospitalization significantly leads to a lot of death in those patients within a certain period of time. That was followed up by the GUIDE-HF trial, which actually had a larger group of patients. While CHAMPION was just for NYHA Class 3 patients, the GUIDE-HF trial used patients in NYHA Classes 2 through 4, and also showed similar outcomes, and kind of showed that it was an effective means of treatment or management for patients for a larger spectrum of heart failure. It also allowed us to adjust medications early based on the PA pressures, and this was one of the first trials that showed that a monitoring device could allow us to make treatment changes and make a real-world and show real-world application of the data that we pull from these devices. The cost of heart failure hospitalization is $18 billion or more every year, and it's a large area of research and focus. The Zio patch, one you may or may not be more familiar with. This is a single lead EKG synthetic adhesive patch, FDA approved for use up to 14 days compared to a Holter monitor, which was typically only used up to 48 hours. It's lightweight, it's low profile, it's water resistant, so you can wear it even when you're showering. And in a study comparison, it detected 96 events compared to 61 with the Holter monitor. These are 2 or 3 people that you might recognize here. This is, and if you watch soccer or football, you might recognize this device as well. This is called the Stat Sports Apex GPS Tracker, and this is FIFA and FDA approved. And it's an advanced wearable tech that's on the market that allows you to track and analyze different metrics, like max speeds, total distance that you run, high speed running, intensity and strain levels, and you can actually upload them to your iPhone and then compare yourself to Lionel Messi or this other guy on the left, Harry Kane. These are just some modern kind of cool blood pressure devices. These are cuffless devices in the top right, and they are smartphone based using BCG or ballistic cardiogram, as we talked about before. And then there's also wearable pressure sensors like the Actia bracelet, which squeeze a little bit and are able to work as a surrogate for blood pressure or use it from the wrist. Finally, in the bottom left, this is the Glabella device. It actually has a 3-axis inertial sensor. So it uses vectors on the side of your face and on the front of your face and around your eyes, and is also able to measure blood pressure with relative accuracy as well. Just going through some of the cool devices that are becoming available now. This is the CardioSkin. It's a smart garment with 13 textile electrodes invented by a French company, designed by a French company. The EKG parameters were measured and compared between both techniques, both Holter monitor and the smart t-shirt and was found to have very similar outcomes. Obviously, the diagnostic quality is much poorer for both with walking, but similar outcomes in comparison. I'm not sure why they misspelled positioning here, maybe because they're French. Here is the another device known as the cardiorhythm application. It's a novel smartphone application that actually works without any contact on the patient at all. And what does it do exactly? Although the methods of this study were not revealed, you can take a picture with the application and or place your finger on the device. And this measures beat-to-beat variations in your face color. So this was measured with multiple, a whole spectrum of face colors, and was actually found to be able to detect atrial fibrillation with a sensitivity of 94.7% and a specificity of 95.8%. While I personally feel the utility of this is a little bit limited, I think it's really cool. And also some of the examples that the designers provided were self-administered follow-up after cardioversion, after ablation, to ensure that patients don't go back into atrial fibrillation before discontinuing their anticoagulation, and also facilities like pharmacies or home care environments without EKG accessibility. So what is the prevalence of wearable devices? Some examples are mobile smartphones, smartwatches, and some of the things that we've talked about just now, and as well as multiple devices that are functioning as rings now. There are over 400 specifically wrist-worn devices on the market. Over 90% of Americans own a smartphone. There have been over 1 billion devices used since 2023. And this is a $5 billion market, some estimates up to $25 billion, and only growing every single year. This is no longer confined to basic health tracking. Wearable technology has expanded its purview to encompass prosthetics, exoskeletons, robotics, and has been using AI and machine learning to analyze these massive amounts of data that it collects. So I wanted to talk a little bit about machine learning and the basic concepts of it, since we're going to touch on it a little bit today. While this is a busy slide, I want you to really just focus on this far right column, which shows the potential clinical applications of these devices and using AI and machine learning. The enormous amount of volume that is collected by wearable devices requires intelligent algorithms and computational power to generate meaningful information. I mean, we can have all this amount of data, but what do we do with it, or how do we interpret it? ML, or machine learning, is a method of data analysis that automates that analytical model building, and it has evolved to recognize patterns in data without explicitly programming them to do that for particular tasks. The advantages are adaptability and scalability and automation and handling this multi-dimensional data. It can be divided into supervised, semi-supervised, and unsupervised. And also there's a fourth kind, reinforcement learning. In supervised learning, the outcome variable is known, and the algorithm attempts to learn the relationship between the outcome variable and the estimating variables. For example, the outcome variable will be atrial fibrillation, and then the estimating variables will be EKG data, like a single lead EKG is collected by these devices. Semi-supervised is when you know a part of the data, or rather the outcome variable, and unsupervised learning is when you don't know the outcome variable. So how do these interventions work? Some examples are adaptive understanding, which is the ability of the algorithm to adapt to one's specific habits and tendencies in terms of travel, activity, and mood. For example, when you wake up and you're groaning and Apple Maps gives you your route to work at 6 a.m. That's an example of adaptive understanding. Gamification is integrating elements such as points or achievements into to promote competition and facilitate positive lifestyle modifications. And it's playing really on people's competitiveness. JITI, or just-in-time adaptive interventions, are a special type of adaptive intervention where, thanks to mobile technology like activity sensors and smartphones, an intervention can be delivered in everyday life when and where it's needed. I don't know if anyone's used Duolingo, but when it sends you notifications that you haven't learned Spanish yet. That's an example of that. So I wanted to just give you an idea of the scale of wearable devices. And this is an umbrella study, which is basically a systematic review of systematic reviews and meta-analyses. This umbrella review suggested that interventions that incorporate wearable devices increase physical activity by 1,800 steps per day, walking by 40 minutes per day, and moderate to vigorous physical activity by 6 minutes per day. Some of the other variables that they tested were DASS, which is Depression, Anxiety, and Stress Scale, LPA's light physical activity and quality of life and vigorous physical activity. Changes in these clinical outcomes can be delayed relative to physical activity and may need further follow-up to become apparent. But this umbrella review was relatively comprehensive and looked at a lot of different designs to bring them together. So we would be remiss to not talk specifically about the Apple Watch, which received FDA clearance for EKG and detection of arrhythmia. And there's also multiple external devices like the KardioMobile ECG check, which are supposed to be more accurate for EKG monitoring and can even produce 12-lead EKGs. The PulseSmart, which is also FDA approved to detect PVCs and PACs in addition to single-lead EKG. So what is the evidence for the Apple Watch? The Apple Heart study included almost 420,000 patients without a history of atrial fibrillation. It detected an irregular pulse in 0.5% of participants, which is still a relatively large number. And it detected, using a 7-day follow-up EKG within that time period from detecting the abnormal rhythm, and found atrial fibrillation in 34% of those patients. Some additional benefits are changes in vital signs, or potential benefits. Changes in vital signs or activity levels in patients with valvular heart disease, with coronary heart disease, or heart failure, and creating prediction models for monitoring for the health app on your iPhone for decompensation and adverse events. So focusing on heart failure, one of the issues that we have with heart failure is that when we see these changes that we typically monitor for, say in clinic or when we're talking to patients, weight changes, blood pressure, and heart failure symptoms, these are relatively close to the time when patients are going to require hospitalization for example, decompensation or diuresis. Some of the things that we would love to monitor better for are pressure changes, like we look for with the CardioMEMS device, or autonomic adaptation and even impedance changes. These are when we want to intervene on a patient and be able to monitor them much more effectively. So some devices that have kind of worked on this are the Optival 2.0, which is a Medtronic device implanted into an existing pre-placed ICD, or the Abbott CoreView, which does the same. And some trials that tested this were not very effective because they used single events and they used single metrics, such as atrial and ventricular tachycardia, delivered shock, CRT pacing, heart rate, or rhythm, but without bringing it all together. So bringing it all together is called multiple metric monitoring. So this is an algorithmic monitoring, and this trial that tested this was the Triage HF. Output was displayed basically as this traffic light that represented whether a patient was high risk or low risk. And and high risk status indicated a 30-day heart failure hospitalization risk. Multiple studies using this that have grown out of the Triage HF have showed that patients who are high risk are 10-fold more likely to be admitted with heart failure in the subsequent 30 days. So theoretically, we have a 30-day warning for when a patient might be requiring hospitalization. Recent real-world data from a Manchester, UK cohort found that 60% of heart failure hospitalizations were preceded by a high-risk status within the 30 days as well. So this is another example, or rather a new example of machine learning studies. This is the MUSIC study, multi-sensor monitoring in congestive heart failure, which developed and validated a personalized algorithm to predict acute decompensation in 543 patients with heart failure. It was basically a wearable chest patch that continuously monitored heart rate, respiratory rate, posture, activity level, and bioimpedance, like we talked about before. The algorithm accurately predicted heart failure decompensation with an 83% sensitivity and a 92% specificity, although this trial specifically was limited due to 42% of the number of devices that were used, that chest patch being inaccurate or having just simply poor performance. The LINK-HF is a trial that studied 100 patients and looked at specifically continuous EKG, accelerometry, impedance, and skin temperature, and also used a chest patch. And this one was able to predict heart failure rehospitalization with a 80 to 90% sensitivity. And something I want you to notice when looking at these trials is the variability that we have between these devices. It's difficult to make outcomes decisions based on these devices because of the variability in quality that we see. So in terms of coronary artery disease, this is the effect of smartphone-enabled health monitoring devices versus regular blood pressure follow-up for patients after MI. There's no nice name like we usually get from cardiac trials. This study evaluated the efficacy and feasibility of smart technology to control home blood pressure in 200 patients. And it used single lead EKGs, daily blood pressure monitoring, and weight, as well as continuous step measurements. Patients were contacted basically if their blood pressure measurements were above the pre-specified threshold, or if the EKG that was continuous identified a new arrhythmia. This intervention was also able to replace some of the in-person follow-up visits with telemedicine visits. And based on the outcomes here, we can see that this was a feasible study and acceptable for patients, although did not necessarily improve blood pressure control. I know that we're reviewing a lot of trials, but this is kind of the ugly stepsister of cardiology sometimes. Cardiac rehabilitation, although it is, as many patients might tell you, is very effective and really reduces heart failure hospitalization, helps with patient follow-up, helps with patient compliance, and also helps patients feel better, quality of life, and return to their normal life. The TeleRehab 2 is a randomized controlled trial that used 18-week physical activity telemonitoring intervention on top of conventional cardiac rehabilitation, so in conjunction with it. The telemonitoring intervention used a triaxial accelerometer, basically similar to an Apple Watch, and weekly personalized automated feedback about patients' activity levels. So they would measure the patient's step counts and then encourage them to increase their step count by 10% each week. I think personally I would be annoyed by that, but I think that it worked pretty well for these patients. It actually improved patients' physical fitness, measured by peak maximum oxygen uptake, and showed a trend towards fewer rehospitalizations compared with the standard cardiac rehabilitation group. The second study here is Smart Care, CAD, which used supervised sessions with an exercise trainer by video session, as well as a cardiac monitor, a chest patch during that time. And it was the focus was preventing relapse. Relapse was defined as after this 3-month period when patients stopped the video visits, did they continue to upload their measurements from the device, or did they decrease their exercise by 50%, their step counts? And this was actually a very successful trial, especially in terms of physical activity level. Patients had a 30% increase in activity level after this intervention with the telemonitoring, and very similar quality of life outcomes compared to traditional cardiac rehabilitation. So we would be remiss to not talk about atrial fibrillation in terms of cardiac monitoring, of course. This is the mSToPS or mHealth Screening to Prevent Strokes trial. And this found that AFib screening in asymptomatic high-risk patients with an EKG patch compared with completely non-monitored controls led to an increased rate of new atrial fibrillation diagnosis and anticoagulation initiation. However, these patients also did have higher healthcare resource utilization, as you might imagine, at a time point of 1 year. They also published a follow-up study which measured outcomes at 3 years and found that there was not higher event rates at that time period as well. The question that remains is, does this early atrial fibrillation diagnosis really improve mortality or morbidity. We don't have that data right now because this is an observational study and also subject to lead and length time biases. Just the example of the Zio patch that we talked about earlier in terms of atrial fibrillation, this was basically justified by a 26,752 patient study, which showed increased diagnostic yield compared to Holter monitor after a period of 48 hours, because the Holter monitor can really only be used up to 48 hours, while Zio patch is approved to use up to 14 days. So what are these are some of the clinical benefits that come from wearable cardiac devices, and they also have plenty of overlap and interplay between each other. Really, personalized treatment plans can lead to expanded patient autonomy and compliance, and patients are empowered to take control of their own lives and their own health and create interventions beyond what can be provided by healthcare providers themselves. Some examples of specific cardiac clinical benefits that we talked about today: stroke rehab, cardiac rehab, risk assessment, disease prevention, and even optimized performance. For example, we have a lot of opportunity to work with elite athletes and even athletes in high school and college athletes who might benefit from these monitoring devices. By streamlining evaluation times, continuing to provide continuous monitoring and delivering personalized insights, wearable sensors contribute to better targeted care, at meeting the patient where they're at, and individualized therapy for cardiac patients. So what are some of the limitations of these devices? The question is compliance. I mean, why now? Why patients who might not have complied with what the doctor recommended or what whoever recommended before start to comply when the device is telling them to do so? Another one is health disparities. The term digital divide describes the growing chasm between groups as a result of unequal access to digital technologies, ranging from computers and even the internet all the way down to smartphones and wearables. Groups who are most affected by this are the elderly, the handicapped, lower socioeconomic status, and those who live in rural areas, as we might be familiar with. Apart from access, lack of digital literacy. I myself find myself with every update of the iPhone, I get a little bit more confused. Given the rapidly changing technology landscape, including the continuous emergence of new types of devices, interfaces, and information, digital literacy always remains a moving target. Over 90% of Americans own smartphones, but this percentage is really only 70% in those 65 and older. So, as we talked about before, some of the trials that we looked at bring into question device accuracy. Can we trust the devices when patients come into clinic and they show us an EKG or a single lead EKG that's clearly not very good quality and alerts them to come into the doctor's office and have them checked out? Can we trust the quality of these consumer grade wearables when there's so much variability in the market and so many different options? Over 400 wristwatch devices are available. And how can we say that abnormal findings influence management? We don't have hard outcomes that show us that changing the medication based on what a wearable device tells us really improves outcomes so far. Another issue is integration, efficient integration with electronic health records. We don't have a good way to do this yet, as well as the massive amounts of data that these devices are collecting. We don't have a good way to interpret them in a bite-sized package that we can understand well. Finally, data security and autonomy. With this massive amount of data, who owns it? Is it the company that collects and does the work to collect the data, or is it the patient whose measurements it is? And is it ethical for us to put this into the industry without making this decision or figuring this out prior? And also, is this data even secure? These are some of the research opportunities and collaboration opportunities that are available in the next couple years. The use of wearable devices among individuals with or at risk for cardiovascular disease in the United States is promising, but the integration of wearable devices into clinical cardiology remains in its infancy, with the evidence base continually evolving. Challenges like device accuracy, clinical validity, regulatory policies, and privacy concerns require attention to ensure widespread adoption of these devices at every level, despite disparities in access. Research initiatives should also focus on comprehending the demographic patterns of wearable device uptake, and the willingness of users to share that data with clinicians. So these are some of the gaps in research and knowledge that I personally noticed while reviewing the existing literature in 4 basic kind of high-yield regions of cardiology. In terms of atrial fibrillation, while many of the existing gaps are being addressed by ongoing studies, it remains unclear whether improved AFib detection will reduce hard clinical outcomes with an acceptable safety profile. Is the earlier diagnosis of atrial fibrillation really helping patients, placing them on these medications and anticoagulation? A lot of the studies that we have now are primarily predictive models and really don't have hard outcome data. Current literature has raised concern about the accuracy of wearables, as we mentioned before, for atrial fibrillation detection, and multiple studies have found notably worse performance of these consumer-grade wearables compared to the industry. This is kind of just highlights the need for rigorous real-world validation in clinical settings. In terms of heart failure, future studies should use wearable devices in large randomized control trials to further clarify utility of the wearable devices for remote heart failure management. Studies could evaluate whether notifications from wearable devices can improve heart failure outcomes and quality of life, along with a significant issue, increased adherence to prescription of GDMT and diuretics compared to standard care, which is right now. Only around 50% of cardiovascular patients or cardiology patients are compliant with medications. Heart rate and blood pressure monitoring from wearable devices may provide clinicians with useful information to up-titrate and adjust medications in GDMT, and we need outcome data that shows us that this is viable and that this is safe and effective. In terms of physical activity, while these are one of the most researched areas of wearable cardiac devices, we need more long-term follow-up to capture the physiologic benefits that emerge after consistent changes in activity for patients. Finally, in terms of cardiac rehabilitation, many of the existing studies use research-grade devices for physical activity monitoring, but recent studies have started to incorporate consumer-grade wearables. The body of evidence for cardiac rehabilitation with wearable devices continues to grow, and we need to work on investigating ways to maximize the durability of cardiac rehabilitation. So, some of the future studies and directions. We need studies on specific devices. While it's not really my goal to convince you that one device is better than the other, we need probably standardized protocols to look at these consumer-grade devices. We should focus on hard cardiovascular outcomes. And also, I personally would like to see a shift from physician-directed technology, which means that all these devices are interpreted or evaluated by physicians, and move this more towards a patient-oriented technology where they're able to review their own data and make decisions for their own care and take more autonomy of their own lives, patients. Wearable devices have the potential to revolutionize prevention, revolutionize diagnosis and management of cardiovascular conditions. While patients frequently use wearable devices in their everyday lives, there remain several challenges that we've pointed out today. A collaborative, multidisciplinary approach with industry leaders, with policymakers, with scientists, clinicians, and patients is needed to transform the digital health landscape and allow wearable devices to achieve their full clinical benefits. Thank you. Thank you to Dr. Gross and Dr. Mee, and thanks to Ms. Reagan and her team.
Thank you. If you're viewing online and you'd like to ask a question, please enter it into the chat section and we'll ask for you. For those in the room, do we have any questions or comments? Okay.
Thank you, Vikas. This is great. I think this is a really important, I guess, future area for exploration, or current area as well. One thing that I think is important to keep in mind for all of us as we see more and more of these devices being worn by patients, and Vikas did allude to it, is that there is great potential for these devices to further some of our health disparities that we see. As you mentioned, our older patients, our more vulnerable patients, our patients from lower socioeconomic strata might not have access to or feel comfortable with these devices. And so you might have a widening of this gap where you see like maybe the top 10% of our country just wearing them and having optimal cardiac health, and then a large portion of people not being able to access that. So I think keeping in mind, as you mentioned, making these accessible to people from all economic spectrums and all parts of the education spectrum will be important going forward.
I agree, and especially, one of the reasons that I wanted to focus on cardiovascular outcomes is once we have more outcome data, maybe these devices can be reflected more in guidelines. And progressively from there, hopefully they will be covered by insurance and really address the issue of affordability for those groups that you talked about. So that's kind of the progression that we hope to see in the next 5 to 10 years.
Great talk, Vikas. I just had a quick question about, I know we're talking about affordability, and I may not know this, but in terms of like those heart failure devices that you mentioned, do we know what the cost range is? Because I know a lot of times heart failure patients don't have enough money, at least for GDMT, so how will they be able to afford these devices to monitor them outpatient?
This is definitely an issue. I think maybe one of the ones you're talking about might be the CardioMEMS device. And typically actually the indication for this device is after one heart failure rehospitalization, it can be indicated for certain patients. I think we typically tend to use it for NYHA class 3 and 4 patients. But even now it's really underutilized. And one of the issues is affordability. And then, also another question is compliance. So if patients show compliance and have issues with affordability, a lot of these are covered by insurance. But the issue remains that actually I've seen multiple patients with Medicaid covering this device for recurrent heart failure rehospitalization. But you're right, it is an issue. And some of the devices like the chest patches that we talked about for some of the other heart failure monitoring are not even in the conversation right now.
Awesome. Thank you.
Thank you.